the motor cortex till the spinal cord, anterior horn of spinal cord, or the cortex or the cranial nerve nuclei. And from that, the lower motor neuron starts to the skeletal muscle, which are voluntary because it is a motor pathway. Okay, now any lesion to the upper motor neuron causes upper motor neuron palsy. It is common sense, and for that, damage to the anterior horn cell of the spinal cord or the cranial nerve nuclei, above which causes upper motor neuron palsy. The characteristics of upper motor neuron palsy are spastic paralysis. Now, why is it spastic paralysis? Because it is characterized by hypertonia and hyperreflexia. Hypertonia caused by alpha motor neuron, which increases the muscle tone, and gamma motor neuron, which increases the sensitivity of spindles. Basically, when the upper motor neuron are damaged, the pathway which inhibits the alpha motor neuron also gets damaged. So alpha motor neuron activity increases, which causes increases in hypertension, hypertone, and gamma motor neuron also increases, causes hyperreflexia. Now the characteristics are Babinski sign, pronator diff, and Hoffman sign. The Babinski sign, the great toe is dorsiflexed and the rest of the toes are fanned out. In the pronator diff, the hands goes down and is pronated, and in Hoffman signs, the fingers are affected. The superficial reflexes are lost, but the deep reflexes are exaggerated, with clonus is present. This usually affects the lower half of the face and upper and lower limbs. Now there are various places where the upper motor neuron can occur. First is the cortex or internal capsule. Basically, before the desiccation causes contralateral hemiplegia. After the desiccation causes ipsilateral hemiplegia. In the cortex and internal capsule, this affects the lower face and tongue. In the midbrain, it affects contralaterally hemiplegia and ipsilaterally oculomotor, because the third cranial nerve nuclei, which is oculomotor, passes directly in the midbrain. In the pons, it causes two syndrome, Raymond syndrome and Miller-Guilbert syndrome. In medulla, it causes crossed hypoglossal paralysis, and in spinal cord, it causes Brown-Sequard syndrome. This is taken from BDC. Now the main difference between upper and lower motor neuron lesions, this is due to damage above the anterior horn cell and the cranial nerve nuclei. This is caused at the junction or below it. So the atrophy in upper motor neuron is disuse, because in the upper motor neuron lesion, at least some part of the muscle is still functional. So it causes disuse atrophy. Whereas in lower motor neuron lesion, the lower motor is completely damaged. So the nerve supply to the muscle is greatly affected, which causes denervation atrophy. Similarly, in upper motor neuron lesion, you can remember it is hypertonia and hyperreflexia. Lower motor, hypotonia and hyporeflexia. This causes spastic and this causes flaccid paralysis. Now the Babinski, pronator drift, and Hoffman sign are present along with clonus. Now fasciculation and fibrillation. Basically, these are the involuntary muscular contraction which causes due to increase in the receptors. That is another topic in itself. Now the typical causes for upper motor neuron lesion are stroke, multiple sclerosis, cervical spondylitis myopathy, ALS, that is amyotrophic lateral sclerosis, and spinal cord injury. While in lower motor neuron, the particularly poliovirus, poliomyelitis, GBS syndrome, peripheral neuropathies, and ALS. Now I will like to call upon next speaker, which is Hora, who will discuss upon the cases of the hemiplegia, which includes this upper motor neuron. Thank you.
Good morning, my name is Hora Ali and I'm roll number 37, and I'll be speaking on the case study of hemiplegia. So for the case study, we have Mr. Mangesh, who's a 50-year-old male. He lives in Mumbai but has migrated from MP, and he is a mechanic by occupation. So during his working hours, he felt a right-sided numbness and slurred speech, which is dysarthria. So his chief complaint that he was brought in for is that is onset right-sided weakness and difficulty in speaking for last 4 hours. So for the history, we have that when he was checked upon, he told us that in the morning he was fine, but then started experiencing slurred speech, and while he was checked, there was seen that there was no progression after onset, and he was found with no headache, vomiting, seizures, LOC, chest pains, or visual symptoms, and he was reached the hospital within the 1 hour, which is the golden period. This is how he was presented in the hospital. In general examination, it was found that his respiratory rate and pulse were within the normal range, but his BP was slightly elevated. He was conscious and oriented, but expresses aphasia and and a right central facial droop was seen with dysarthria, that is slurred speech was present. There were no signs of pallor, cyanosis, jaundice, edema, and dehydration. Now I call upon Ratnadeep for the next topic.
Hello everyone, my name is Ratnadeep, roll number 31. Today I will be presenting the local neurological examination and differential diagnosis for hemiplegia. So, moving on to the inspection, local neurological examination. My findings are characteristics of left upper motor neuron. On inspection, I found right lower facial palsy, flaccid right hemibody, arms wear, hanging limb, and leg dragged. No atrophy or fasciculation found. Tone was hypotonia in right limbs. On inspecting power and tone, power was 1/5 MRC, which is Medical Research Council's scale. Abduction of shoulder and elbow extension. Reflexes were initially 2+ bilaterally, then begins to emerging briskness at knee and ankle. Positive Dubinsky sign is the important findings. And then sensory, light and touch pain was initially intact. Then we have differential diagnosis. The most important is acute ischemic stroke. Then least likely are intracerebral hemorrhage, brain tumor, subdural hematoma, towards paralysis, and metabolic hypoglycemia. Thank you.
My name is Hikisha, roll number 39. My topic is investigation, diagnosis, and lesion description of hemiplegia. The Charcot artery hemorrhage is a rare but serious condition. This artery supplies the deep parts of the brain, which includes the internal capsule and the basal ganglion. This artery can rupture in cases of hypertension, that is high blood pressure leading to intracerebral hemorrhage. This can be detected by non-contrast CT scan, MRI scans, and CT angiography. In non-contrast CT scan, the fresh blood is detected. It is showed hyperdense as compared to the brain tissue. This happens because of the high content of protein and iron in fresh blood. This is used for quick diagnosis because it is detecting fresh blood. Second is MRI. In MRI, it detects blood at different stages because it appears differently. If it is at different stages, it will be showing differently in the MRI scan. Also, it can detect small amounts of bleeding in the brain. So this is a very good diagnosis technique. Third is CT angiography. In this, it detects active bleeding because when the blood is coming out, the contrast dye also leaks with it, and it forms a bright spot called the contrast extravasation, which shows that there is active bleeding. The 3 steps in the diagnosis are medical history of the patient, examination, which is systemic and neurological, and investigations. In investigation, we see in the NCCT scan that it shows hyperdense MCA sign, which implies that there is a clot in the artery. In MRI, we find that there is a bright area on the diffusion weighted imaging in the left middle cerebral artery territory, which is the area which is supplied by the MCA. In CTA scan, that is CT angiography, it shows blocked left middle cerebral artery, and hence the final diagnosis is that acute ischemic stroke in the left middle cerebral artery territory. It is confirmed. The lesion description, the lesion is an acute ischemic infarct in the left middle cerebral artery, which constitutes the upper motor neuron pathway disruption contralateral to the right-sided hemiplegia. That is why the right side of the patient was affected, because the left middle cerebral artery, we saw the clot. Thank you.
Morning everyone, my name is Abhishek Kule. My roll number is 32. My topic for today's seminar is upper motor neuron hemiplegia treatment. Basically it involves 2 approaches. First is acute medical management and second is rehabilitation. So acute medical management mainly focuses on saving the life of the patient and preventing further damage of the brain. And second is rehabilitation, which mainly focuses on giving functional independence to the patient for its daily activities. Acute phase treatment. This focuses on stabilizing the patient and managing the hemorrhage, hospitalization and ICU care, monitor vitals and neurological status. When the patient is admitted in the ICU, mainly we have to manage his vitals and other neurological status, because BP and consciousness of the patient is very important in such cases. Control of intracranial pressure is essential. It includes elevating the head of the patient. The bed is essential, administrating osmotic diuretics like mannitol and ensuring adequate ventilation. As shown in the diagram, the head of the patient is elevated at 30 degrees so that the venous drainage is proper and so that intracranial pressure should not increase by accumulation of blood. Blood pressure management. Lower high BP carefully. So drugs like labetalol and nicardipine are very useful for this purpose. These drugs lower the blood pressure very efficiently, and they do not affect the brain that much. Surgical intervention. Craniotomy or decompressive surgery if there is a large hematoma. If there is a large hematoma present, we perform craniotomy or decompressive surgery. In craniotomy, we remove the skull and remove the hematoma. In decompressive surgery, we remove a specific part of the brain where the hematoma is present. Hydrocephalus can be managed with ventriculostomy to drain the excess fluid. In hydrocephalus, there is unusual accumulation of CSF, in which ventriculostomy is useful. Second approach is rehabilitation, aimed at functional recovery and neuroplasticity. Rehabilitation mainly focuses on giving functional independence to the patient for its daily activity, like shown in the first diagram. And second, so that the muscle of the patient should not be affected that much, and they will be recovered after that surgery and other treatment. Physical therapy, range of motion exercise to prevent contractures, strengthening and balance training, gait training, as shown in the first diagram. Occupational therapy, training in activities of daily learning, dressing, bathing, feeding with use of adaptive equipment, scents and environmental modification in hemiplegia. As shown in the diagram, we help the patient for its daily activities and helps for its recovery. Thank you.
Hi everyone, myself Nivedita and today I am going to present on upper motor neuron and lower motor neuron. Upper motor neuron lesion. An upper motor neuron lesion is caused by the damage in the pathway that originates in the motor cortex and travels through the spinal cord and reaches the spinal cord to control movement. These pathways normally modulate and regulate the lower motor neuron. What gets damaged in the upper motor neuron? Upper motor neuron runs from motor cortex through the brainstem into the spinal cord. Damage in this region produces the characteristic patterns of sign. Classic signs of human lesion: weakness, muscles are weak but usually not profoundly atrophied early on. Increased muscle tone, muscle feels stiff, resistance increases with a faster movement. Hyperreflexia, exaggerated deep tendon reflex. Babinski sign, toes extend upward instead of curling downward. Minimal fasciculation, twitching is uncommon compared to element lesion. Common causes are stroke, spinal cord injury, cerebral palsy, brain tumor, and multiple sclerosis. Anatomy of lower motor neuron. Lower motor neuron is the pathway that connects nervous system to the skeletal muscle. Element lesion occur when there is a pathway disrupted when it leaves the spinal cord or brainstem. Because element injury causes a loss of muscle contraction, loss of reflex output, denervation, changes in the muscle. Effects of element damage: flaccid weakness, hypotonia, hyporexia, severe muscle atrophy, fasciculations, and no Babinski sign. Common anatomical sites of lesion: anterior horn cell polymyelitis, ventral root radiculopathy, peripheral nerve trauma neuropathy, and neuromuscular junction causes the myasthenia gravis, and muscle causes myopathy. Thank you.
Good morning everyone. My name is Krishna Gimbal, roll number 33. My topic is gait. So gait is a coordinated, rhythmic and alternating movement of the limb and trunks that produces locomotion. It may be abnormal and normal. It has two phases, acute and subacute. Then we talk about the acute phase. In this phase, the muscles are flaccid paralysis, that is hypotonia. And in this phase, the patient cannot walk independently. He needs support, that is wheelchair or assistance, and also suffer from foot drop due to the weakness of the dorsiflexors, and also suffer from dragging gait and knee bulking due to the dorsiflex weakness. And in this phase, due to the floppy muscles, that is hypotonic, the circumtraction is not seen in this phase. You can see the foot drops pictures. Second, that is subacute phase. In this phase, the plasticity develops due to upper motor neuron lesions, and also we see in the classic hemiplegic circumduction gait due to the increased muscle tone. And in this phase, the patient spend more time standing in affected side, and in this also the patient perform the limited hip and knee movement due to the extensor synergies. This means the legs tend to be stiff leg, and also due to the limited movement, or he cannot flex the knee and hips, so he legs move in semicircle, that is circumduction, and circumduction performed by the hip abduction, external rotation. This compensates the foot drop, and affected side is compensated by the normal side by performing the vaulting, steppage gait, and Tinderbug signs. This will increase the work on the left affected side, work on normal side. And we have key observations. Normally the arm on the affected side swing minimally and remain up flexed at elbow and abducted near the body due to flexor synergies. Also the trunk lean left, that is on the normal side for the balance, and he bent forward. And also we can improve a pattern of the walking by therapy, that is ankle foot orthosis. Thank you.
Good evening, everyone. My name is Harshrup Savre, and my topic is upper and lower motor neural lesions of facial nerve and common differences. The difference between upper motor neuron and lower motor neuron. Upper motor neurons, these are the neurons present in the central nervous system, and lower motor neuron nerves exciting the CNS from their respective nucleus. Upper motor neurons, on the other hand, do not enter peripheral nervous system, and if injured, cause loss of inhibition of lower motor neuron by upper motor neuron. This is also called spastic paralysis. Lower motor neuron, on the other hand, lesion causes complete loss of loss of nerve stimulus, called flaccid paralysis. Lesions, the difference between the lesions of upper motor neuron and lower motor neuron. In upper motor neuron lesions, contralateral paralysis of lower half of the face and forehead muscles are spread, the bilateral representation. And in lower motor neuron lesions, there is ipsilateral facial paralysis, also called flaccid paralysis, and also known as Bell's paralysis. In human lesions, all forehead movements are preserved. On the other hand, element lesions, ipsilateral forehead paralysis, and no forehead movements are preserved. Differences between upper and lower motor neuron lesions. At the level of lesion in human facial palsy, it is above facial nucleus, and in the element facial palsy, it is at or after facial nucleus. Common cause in human facial palsy is stroke, and in element facial palsy, it is Bell's palsy, trauma, or infection. Site of weakness in human facial palsy is contralateral lower face, and in element palsies, it is element facial palsy, it is ipsilateral whole face. In forehead movement, in human facial palsy, it is spread, and in element facial palsy, it is affected. Eye closure, human facial palsy normal, and in element facial palsy weak or absent. Mouth deviation away from lesion, away from affected site. Hyperaxis, there is nothing in human facial palsy, and it is may or may not be present. Element facial palsy. Taste loss in anterior two-thirds of the tongue. In human facial palsy, it is not there, but in element facial palsy, it may be present. And associated neuroscience often present hemiparesis of fascia or usually isolated facial weakness. Thank you.
Good morning everyone, myself Ishwari Munde, roll number 40, and today I'll be presenting a case on human facial palsy. So Mr. Suresh is a 50-year-old male, and he is a shopkeeper by occupation and is a resident of Mumbai. So he presented to the OPD with a complaint of deviation of mouth to the right side and weakness of the left side of the face since 2 days. On checking the present history, the patient was presented with sudden onset and non-progressive deviation of the mouth toward the right side and weakness of the left side of the face for 2 days. He reported difficulty in smiling, speaking, and puffing cheeks, along with drooling of saliva in the left side of the mouth. In this image, we can see that the lower face is weak and it is deviated to the one side, but the upper face is strong and he is able to raise his eyebrows. After checking the past history, he was known to be hypertensive for 10 years on irregular medication. There was no history of diabetes, previous stroke, malignancy, smoking or alcohol use. The vitals show that the pulse was regular, that is 88 beats per minute. The BP was raised, that is 170 upon 100 mmHg. The respiratory rate was regular, that is 18 cycles per minute. No pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy were seen. On examination, it was found that there was flattening of the left nasolabial fold. The angle of mouth was deviated to the right. There was facial asymmetry at rest. The forehead wrinkling was preserved bilaterally. The eye closure was normal, but there was left platysma contraction. Thank you. Good morning everyone. I am Alisha Gagdilwar, roll number 45. I am presenting a case of lower motor facial palsy. So the patient name is Mr. Ramesh. He is a 60-year-old male. He is a retired clerk who is a resident of Mumbai. He came to OPD with sudden onset of left-sided facial weakness for 1 day. History of present illness. The patient presented with a sudden onset of weakness and was maximum on the onset. He reported to inability to close the left eye, drooping of left eyelid. The mouth was deviated to the opposite side. The mouth was drooping and drooling of saliva was found. In the image, we can see that the affected side shows loss of forehead wrinkles, inability to close eye, which is also known as lag of thalamus, drooping of mouth, flattened nasolabial fold. Mouth was deviated to the opposite side. While trying to close the eye, the eyeball moves upward, which is also known as Bell's phenomenon. Past history, there was no history of diabetes, hypertension, stroke, trauma, malignancy, no recent dental procedure or ear infection. He does not smoke or consume alcohol. No pallor, icterus, cyanosis, clubbing, edema seen. Vitals were normal. On examination, there was complete left-sided paralysis. Absent of nasolabial fold, he was unable to close his eye, wrinkle the forehead, and inability to smile or puff his cheek on left side. Bell's phenomena was also present. Thank you.
Hello, myself Nidhi Jaiswal, roll number 43. Our topic is investigation of upper motor neuron and lower motor neuron facial path. Patient with facial asymmetry is presented. Forehead movement is present. We suspect hello, am I audible?
Every word should be like thrown in the inside the mic.
Okay.
देखो कैसा होता है तुम्हारा हाथ इधर रहेगा और मुंह इधर आ जाएगा ऐसा हाथ का रहना चाहिए
We suspect upper motor.
अगेन और ऊपर लेके जाओ
We suspect upper motor neuron lesion. For investigation, we do CT scan, MRI, and MRE. In CT scan, we found structural lesion in the brain. In MRI, we found reduced frontal cortical motor areas, and for in MR angiography, we find blood vessel. This is for blood vessels. We detect clotting, aneurysm, and blockage. And for lower motor neuron investigation, now electrophysiological test is done. focus on detecting active and chronic denervation to confirm diagnosis. We have 3 tests: conduction study, electromyography, and electroneurography. In nerve conduction, it measures how fast and strong nerve impulse travels. In electromyography, we detect how muscle and the nerve supplying them are affected. And electroneurography is for evaluation of nerve facial primarily to predict acute facial paralysis. Additional investigation is done in lower motor neuron, MRI for recurrent palsy, progressive weakness, suspected tumor or infection. And the functional test, smear test, tasting test and kernel, all these are supplied by facial nerve, cranial nerve 7. Smear test is for lacrimation, dry eye syndrome, taste testing of anterior 2/3 of the tongue, as it is also supplied by facial nerve. And corneal reflex examination, pen torch is shown to the eye. In the eye, if defective or no movement is detected, then this is due to dysfunction of facial nerve.
Good morning friends, my name is Vedant Mahajan and my topic is differential diagnosis between the upper motor neuron and lower motor neuron lesion. We see about the common causes. First is a stroke. Stroke is the most common cause for the upper motor neuron facial palsy. It is affect the stroke is the interruption of the blood supply to the brain. It is occurs in various regions, but in the upper motor neuron facial palsy, the main area is the cortex or corticovestibular tract, in which if any stroke is occurs, then it can cause the facial nerve, upper motor neuron for facial palsy. Then second is a brain tumor. Brain tumor, if any tumor is growing in the area of the cortex or internal capsule, it affects the upper motor neuron facial nerve pathway. And then the multiple sclerosis. Multiple sclerosis is the autoimmune disorder which in which the unmyelination of the CVS occurs. Then next is a trauma to brain. Any trauma to the brain in the accidents or intracranial hemorrhage, the upper motor neuron pathway is affected. Next is intracranial infections. The infections like meningitis, encephalitis can be occurs. Then the lower motor neuron facial palsy, in which the main common cause is Bell's palsy. Bell's palsy is due to the HSV, which is herpes simplex virus. It causes in the facial canal due to inflammation or the edema. Next is a Ramsay-Hunt syndrome, which is occurs due to the reactivation of the VZV, which is a varicella zoster virus due to in the geniculated ganglion. Next is otitis medius. It is an infection which is passes through the ear. In otitis medius, the symptoms can be ear infection or ear dropping or losing of hearing. Next is trauma to facial now. If any accidents occur in the things, or if the temporal bone is fractured, the trauma occurs in facial now. Then parotid gland tumor. In parotid, the facial nerve passes through the parotid gland, but it cannot supply to the parotid gland. If any tumor occurs there, which compresses the facial nerve, due to which the lower motor neuron lower motor neuron pathway affected. Last is diabetes mellitus. It is in diabetes mellitus, the sugar level is high, due to which some in some cases due to diabetes mellitus, some nerves are affected, in which the facial nerve is one of them, due to which the blood vessels are affected, and due to blood vessels the blood is not completely, not enough blood is supplied to the nerves, due to which the nerve supply, the conduction of impulses or nerve supplies cannot occurs. Then the key differences in which the key difference is the forehead spade. In the upper motor neuron lesion, the forehead spade is the most commonly visible. In the lower motor neuron, the ipsilateral complete facial weakness is there. In upper motor, with often other neurological defects also seen, and in lower motor may include taste blood and hypercosis. Thank you.
Hello, check. Good morning everyone. My name is Sanskar Ramgiri and my roll number is 34. Today we will be learning about the treatment and final diagnosis about the about case. So let's start. First we will start with the brief explanation of the lesion. The lesion is supranuclear, that is corticobulbar lesion on the right side. Second point is upper face is spared because of the lesion, because the upper part is the upper face is spared because it has the bilateral cortical innervation, and the lower face is weak because the on the opposite side, because the contralateral deviation mouth deviation and weakening of the smile on the opposite side. Associated involvement of corticospinal tract explains the contralateral hemiparesis, increased tone and hyperplexia. The diagnosis is left-sided upper motor neuron facial palsy with the left body weakness due to right-sided ischemic stroke caused by the uncontrolled hypertension. Let's start with the confirmatory test. The confirmatory test includes the CT scan of brain, then MRA, that is magnetic resonance of angiography, and then it also includes NCCT scan of the brain, that is non-contrast CT scan of the brain. First, it is used first line to rule out the intracranial hemorrhage and detect the early ischemic changes. Second is MRI of brain, that is with DWI and FLAIR. DWI stands for diffuse weight investigation, and FLAIR stands for fluid accumulated inverse resonance. Gold standard to confirm the acute ischemic infarct. MRA or CT scan of CT angiography to identify large vessels occlusion or stenosis. Stenosis means there is when there is blockage of some blood vessel. Then fourth is ECG and electrocardiography to look for the embolic source and blood investigation. That includes CBC and lipid profiles and blood glucose levels to assess the vascular risk factors. The treatment includes the acute care, means first we have to stabilize the BP and the blood pressure, BP and stabilize the patient. The second includes antiplatelet therapy. Start the aspirin after ruling out the hemorrhage on CT scan. The third includes thrombolysis. Thrombolysis means dissolving the blood. After, when the patient is in treatment window, means it's in scope of treatment, then we can start the thrombolysis. Fourth one is supportive therapy. Supportive therapy includes physiological therapy and the speech treatment. And the last one is secondary prevention, which includes the strict precaution of BP and modification in lifestyle. Next, I would like to call Prithviraj for the detailed explanation of treatment on facial palsy and both only. Thank you.
Good morning friends, my name is Prithviraj Motiram Kadam and my roll number is 44. My topic name is treatment of facial palsy of both the lesions. We know the causes like Bell's palsy is there, herpes zoster is there, or the nerve damage is there. When there is a treatment, the general treatment starts with the steroids. The general corticosteroids, short-term corticosteroid therapy is recommended for all the patient. It starts within the 3 days, and its oral dose is like the Pedroson, which is 60 to 80 milligram per day for 1 week. If there is a severe case of facial palsy, the antiviral therapy along with the corticosteroid is recommended, and the oral doses which are given like the valacyclovir 1000 milligram 3 times daily for 1 week, which is most preferred. And there is also a cyclovir 400 milligram 5 times a day for 10 days. In this situation like facial palsy, the eye care is very essential because there is inability to blink the eye. So the artificial tear drops 4 to 6 times daily it is used, and it can't blink the eye, so the eye tapes can be used to close the eye. And along with this surgical treatment, the rehabilitation is there, which supports it, like physical therapy is there, facial nerve exercise is there. And if there is a severe case of the facial palsy, the surgical intervention is also can be done, like decompression and the nerve grafting can be considered. And the treatment, if it ends, there is a follow-up for the treatment. Recovery is from the 3 weeks to the 3 months. Majorly 80 to 85% of patients are the recovered. In the severe case, like we can consider for the Botox injection. And if there is a worsening of facial weakness after 3 weeks, it is called as diplopia ataxia, and we can consider the MRI for the further treatment. Next is a treatment of upper motor neuron facial palsy. The major cause is, we know that it is stroke. It can be due to the trauma or the tumor. What is main in the treatment? First is they treat the underlying cause, prevent the complication, and start the early rehabilitation. The general treatment is same like the previous, but now we'll see the treatment based on the causes, like it is due to the stroke, brain tumor, or multiple sclerosis. If it is due to the stroke, there are the two, like it may be due to the acute ischemic stroke, where IV thrombolysis, which is given in the within the 4.5 hours. And it may be the hemorrhagic stroke, in which the BP is controlled, blood sugar, lipid, and there is the intracranial pressure management. If it is due to the brain tumor, the surgical removal of the brain tumor can be done, or the radiotherapy or the chemotherapy can be done in this. And if it's due to the multiple sclerosis, high doses of the corticosteroids are given. Along with this, the treatment, the supportive treatments is also important, and which are the like facial weakness management, speech therapy, eye care, if there is an incomplete closure of the eye. And also with this, the rehabilitation also helps, like early physiotherapy, occupational therapy, physiological supports, and the regular follow-up. Thank you.
Good morning everyone. My name is Parjagar Pure, roll number 42. My topic is recent advances in facial nerve palsy. It can be categorized into central upper motor neuron or peripheral lower motor neuron, that is Bell's palsy. Few of the advances are HBOT, hyperbaric oxygen therapy. It improves oxygen supply to nerve, it reduces edema, and it also accelerates the nerve recovery. The next one is TMS, transcranial magnetic stimulation. It stimulates the brain cortex and improves facial muscle function. Next one is low level laser therapy. It reduces inflammation and it also promotes nerve regeneration. Next one is botulinum toxin. It treats synkinesis. That synkinesis means abnormal movements, and it improves facial symmetry. Acupuncture improves blood circulation, and it also supports healing. Upper motor neuron facial nerve palsy. Some of the advances are thrombolysis and thrombectomy. It restores blood supply, it prevents permanent nerve damage. Electrical stimulation and TMS improve neuroplasticity, and it enhances the recovery. Some of the future advances are growth factors like VEGF, that is vascular endothelial growth factor, and insulin-like growth factor. It promotes regeneration. Next one, stem cell theory. It repairs the nerve. Next one is artificial nerve grafts. It replaces damaged nerve. And last one, machine learning predicts recovery. Thank you. This concludes our presentation. Thank you for your attention, and thanks to our mentor, Dr. Sania ma'am, for guiding us.
Very nicely presented, and only thing you have to practice is this. So next batch teacher, please remember, सब लोग ऐसा उल्टा उल्टा चालू करें, otherwise it was good. And आपने दोनों किया क्या साथ में? अपर दो केसेस, एक अपर भी और
3 cases.
okay. So it's very easy for us to present the case, but let me tell you, stroke is Bell's palsy is still, person recovers, comes out of it, because that the sternomastoid foramen is too small. So वहाँ पे कुछ भी थोड़ा viral infection, inflammation हुआ तो Bell's palsy होता है, but वो eventually ठीक होता है. Stroke is a horrible thing that can happen to anyone, because with stroke what happens is brain का जो damage हो गया ना, it happens by two ways. Of course वो खाली मुझे दिखा नहीं कहीं पे, आपने बोला कि because of vascular, there are two things that can happen. One is some vessel getting blocked, that is ischemic stroke, and two is a vessel getting burst. So in case of hypertension, the getting burst is very common. The Charcot's artery, what they were talking about, वो इतनी बार हीमरेज हो गया कि वो इतना बदनाम हुआ है कि उसका नाम ही Charcot's artery of hemorrhage हो गया. They call it Charcot's artery of hemorrhage. But all of you presented very nicely, so congratulations to the batch, and I request Sania ma'am to please come and speak a few words. तू है ना गाइड, तू है हाँ गाइड है ना तू, बोल. बंद करना बंद कर सकते.